Good morning or good afternoon. My name is Monica Pica. I'm with Sachs Healthcare, and I will be your technical producer for today's webinar. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available soon after the session. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing enter. Our speakers will try to answer as many questions at the end of the presentation as time allows. If you experience technical difficulties, please use the Tech Support tab, also located on the right-hand side of your screen. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC, or Command R if you're using a Mac. Please make sure you are not behind a firewall to view and participate in this webinar. A firewall may prevent you from viewing this event. Our moderator today is Angela Craig. Ms. Craig is Clinical Nurse Specialist in Critical Care for ICU at Cookeville Regional Medical Center in Cookeville, Tennessee. She is also the Sepsis Coordinator for her hospital and is a Network Advisory Committee member for Sepsis Alliance. An expert in the field of sepsis awareness and management, Ms. Craig has published on sepsis and heart failure and has lectured extensively at numerous nursing conferences and webinars on the topic of sepsis and hemodynamics. Welcome.
Thank you, Monica, for that very kind introduction. Good morning, good afternoon, everyone. The title of today's webinar is Assessing Ventilation and Blood Flow with Capnography. Speaking today on this very timely topic is an expert and a colleague, Tom Ahrens. Tom Ahrens is one of the founders of Vivint Health. Dr. Ahrens has more than 25 years of experience as a critical care nurse and is the author of 5 books, more than 100 papers, and more than 40 scientific publications. His book, Essentials of Oxygenation, received the Book of the Year award from the American Journal of Nursing. He is a recognized authority in sepsis and has given numerous lectures around the country on this subject. On this subject. Dr. Ahrens is a fellow of the AAN, which named him one of its first Edge Runners in 2006. The award recognizes innovations resulting in better care for patients, family, and the community. Just a moment. Thank you. Our speaker has no disclosures to report. As far as I've got my notes here. I'm so sorry. He has no conflict of interest or no financial relationship for this webinar. This activity has been approved for 1 contact hour for nurse, RT, and EMS professionals. A link to obtain credit will be available at the end of this webinar. The accreditation statement is listed below, and support for this educational activity has been provided by Philips. So now, without further ado, I'm going to turn this over to speaker and my friend, Tom Ahrens.
Thanks so much, Angela. Again, it's always a pleasure to see you. Again, welcome everybody. The topic today is actually a really good one. It's the idea of capnography and how it measures both ventilation and blood flow. And hopefully many of you are already using capnography on a regular basis. Its use is just really astounding in how much it can do for us as a clinician. And we'll go over a couple of these things just to show really when you look at how we would use capnography. We'll cover some of these learning objectives. But if I had to pick one monitoring tool for a patient, it would be a capnogram. And you'll see very clearly as I go through this why that's the case. We'll talk a little bit about relationships between the arterial carbon dioxide level and the end-tidal carbon dioxide level. We'll go over why capnography is a rapid assessment of inadequate ventilation and perfusion. We'll go over how capnography can identify a patient at risk for over-sedation, and we'll go over how we're going to look at capnography for blood flow monitoring. So when we start this presentation, like I said, this really could be considered the newest vital sign. And if you really had to have one more than heart rate, respiratory rate, blood pressure, I would choose the capnogram. And the reason for that is very simple. It assesses both the person's breathing and their blood flow, their cardiac output. So the reason capnography can reflect both ventilation and perfusion is, and we'll talk about this slide again later, under normal circumstances, as blood returns back into the lungs, CO2 rapidly diffuses. You probably all know that CO2 diffuses 20 times faster than oxygen. And so very quickly, the venous CO2 level will go into the alveoli and then be exhaled. And that's what we're measuring with capnography, is the exhaled carbon dioxide. Now, if we, for any reason, reduce ventilation, the exhaled carbon dioxide level is going to go up. If for any reason we reduce perfusion, like in this example here, we show a pulmonary embolism, then what's going to happen is we'll have less carbon dioxide being added to the alveolus, and what will occur is the exhaled carbon dioxide level will drop. That's it. That's how simple this is. What we'll do over the next several slides, though, is show you how we're going to be able to use this in clinical situations. So what to start to go concept, look at it. Very simple. Mind CO2 level, carbon dioxide is ever goes up, something's wrong. Maybe it happens. You ever seen that have a
Excuse me, Tom, just for one moment. We are experiencing just a little bit of audio difficulty. So let me just pause you for just one moment, Tom, and we're going to get Tom's audio a little bit better. Thank you. Just one moment, please. Okay, Tom is back. Thank you so much for your patience. Go ahead, Tom.
Okay, it looks like we're having some audio and visual difficulties. So what we want to do is to, again, look at how we would apply capnography. And I want to show you again how simple this is to do. Monica, can they see my screen? Because I'm not seeing my screen pop up. Sorry, everybody, for this.
Yes, we can see your screen. Yes, we see the screen. Thank you.
Got it. So what I want to do is, again, we'll catch up on all this. And again, the principle of going through that capnography is really so easy and simple. We can do it really quickly. But what you see on the screen here, there's two things. One, on the left-hand side is you see a handheld device, and you can see the end tidal CO2 of 39 and the rest rate of 19. And then on the other side, you'll see a monitor that shows an end tidal of 30. Now, the reason I want to show you this is when you look at summarizing everything there is about capnography, that number 30 becomes very important. If you put a capnogram on a patient, say they're newly admitted, you're on a rapid response call, and you get a capnogram reading of 30, your patient's safe. They're both breathing okay and their ventilation is adequate. The only time that we worry about a patient is really if their capnogram is low or if it starts to go high. So what I want to do is go through, again, some examples of this, and I'll show you a picture. This is just me wearing a capnogram. You can see how easy it is to do. My end tidal is reading 32 and my rest rate's 22. Again, and like I said, as long as the capnogram is reading 30 or more, you have adequate perfusion. So as we go through this, we can also put this in place on people who are on ventilators. And this next slide shows the patient who's on a ventilator and just shows this is a mainstream CO2 analyzer or a side stream. But here's what we're looking for. We're looking at a capnogram. The capnogram has different components. The number 1 reflects a rapid drop in the carbon dioxide level, and that indicates an inspiratory effort. And we can go into some other details, like number 2 shows the alveolar emptying starting to occur. What you want to see in a capnogram is this number 3, where you have a nice flat alveolar plateau. And then we get to number 4, which is the end tidal CO2 level. So this is the level that occurs just before the person will take an inspiration. So this is what we call the end tidal CO2 level. Now, what we're looking for in a patient is anything that might change this waveforms pattern. So if you look at this top example, notice that it has a very short exhalation and a very long inspiration. This is taken from a patient who has asthma and is having trouble breathing, trouble exhaling. What we want to see, and we can use a capnogram even for the assessment of bronchodilator therapy, if a person starts to improve their breathing and they start to have less airway obstruction, you'll get a return to the nice flat plateau phase. So what a capnogram can do is indicate when a person is actually breathing effectively or not. Now, when we look at the applying capnography to ventilation, again, it becomes very simple. Normal end tidal CO2 levels are just a few millimeters that's going to be below arterial carbon dioxide level. So if your arterial carbon dioxide level is 40, normal end tidal might be 35. So if you're at a patient's bedside and you see they're having a end tidal carbon dioxide level increase, say even by as little as 5 millimeters, you should start to be concerned. If it goes up by 10, you really need to be considering supporting the patient's breathing. Or if you've given them sedation, you might have been given them too much. Because the normal drive to breathe is so strong that a slight increase in the carbon dioxide level would trigger breathing to reduce it back to normal. So if I see a patient who is not reducing their carbon dioxide level back to normal, then we know that something's wrong. And really, this concept is at the heart of using capnography to monitor patients in terms of understanding, is this person getting adequate breathing or not? Now, first of all, that's really all you need to know. I'm going to go into some details regarding capnography and its use. Bottom line is, if we see a capnogram go up, and certainly go up by 10 millimeters or more, you want to be concerned. You can always get a blood gas to make sure that the capnography level is increasing along with the arterial level. And certainly the pH would tell us how much danger you're in. But the capnography level by itself, if you're monitoring it, that alone is a warning sign. Now, if I were to compare a capnogram against an oximeter, a pulse oximeter, there really isn't a good comparison in terms of assessing ventilation. A pulse oximeter is very good at detecting oxyhemoglobin levels. What it's very poor at is identifying ventilation. And partially that's related to the oxyhemoglobin dissociation curve. And we don't need to go into great detail on this, but let me just give an illustration. If I have a patient who has a capnography or an end tidal level go up by 10, that the assumption is their arterial level is going up by 10 as well. Well, what that'll do will displace oxygen by the same amount, 10. Now, based on the oxyhemoglobin dissociation curve, let's say the PO2 was 90 to start with and it decreases to 80. Both clinically okay. That would cause the saturation to drop from 98 to 97%. Again, that's from the oxyhemoglobin dissociation curve. That wouldn't raise a concern. As a bedside clinician, you wouldn't even note a change of 98 to 97. So the oximeter is not sensitive to changes in the arterial carbon dioxide level. And then if you add oxygen to the person, that pretty much eliminates the ability of the oximeter to warn you if something's occurring. And again, I'll give an example. If you have a procedure, whether inpatient or outpatient, and I'll use the example of colonoscopy, if you put the person on oxygen, you've now really limited the ability of an oximeter to warn you if something's wrong. Now, the capnogram isn't affected by that. So the point being is, if I'm going to have a monitor on somebody to assess their breathing, what I want to have is a capnogram more so than an oximeter. And I'll just show you a slide that kind of illustrates this point, is that when you look at this example here, notice that when we look at the PO2 and the pulse oximeter reading, that we have a drop from 95 to 80. That caused a tiny drop in the pulse oximeter reading. But if you look at the end tidal CO2 level, that went up from 39 to 54. Now, this is a patient we had in a research study, and notice we were drawing a blood gas as well, and the pH dropped significantly. But if I'm watching the oximeter alone, then I'm really not seeing a change that would warn me that there's a danger. Now, this patient was then given oxygen, and notice the oximeter went back up to normal. I think that this would, if you're watching the oximeter alone, you wouldn't be worried. But if you watch the capnogram, it's rising alarmingly high. So what we want to be able to do is make sure that we can recognize when our patient's at risk. So I'm going to show you just a real quick, a couple of cases that illustrate this point. So in this slide here, this is the patient who had a colonoscopy being done. And the first column, he has a heart rate of 72 and to begin with. And notice throughout the whole procedure, it never increases very much. The second column is his respiratory rate. The respiratory rate goes from 12, stays no more than 10. That wouldn't worry you. Same thing with the blood pressure in the third column and the pulse oximeter in the fourth column. But notice what's happening to the capnogram. The capnogram is increasing the whole time. And this would be the warning sign that too much sedation has been given. But if you don't have the capnogram, if you don't have that last column, you won't know what's occurring. And so because of that, we really have an issue if you don't have capnography to monitor patients. This next example here would be an illustration of something very similar. This patient is being weaned from ventilator, and we put them on a side stream or just a handheld end tidal CO2 monitor. Notice that during this weaning attempt, this person did very well by traditional parameters, but not by the end tidal. And so what happened is this patient had to have the weaning attempt terminated. But if you don't have the capnogram, you don't see that. And so the point being is that we want to be able to fairly quickly identify a danger, and the capnogram lets us do that. Let me skip that last example just for time's sake. This next case, this case 4, is a patient who was a complicated patient, but I want to show you what happened here. This patient came into the medical intensive care unit. He was very sick. He actually, turns out, he had miliary tuberculosis. And he was very tachypnic on admission to the ICU. He was intubated, and then he extubated himself. And so to try and help him not extubate himself again, they gave him sedation. Well, notice that the end tidal went from 33 to 47. But if you take a look at the other parameters, you might not be worried about that. So, for example, his heart rate came down, his rest rate came down. Well, that was because of the sedation. And so the problem comes up with this is the end tidal level climbs alarmingly high. This patient needs really to have the ventilator increased in terms of its support. What I want to go through on this is that the end tidal is what's warning you that something's wrong. Now, this isn't a recommendation from me as a person to you to use capnography. Certainly in things like with the standard anesthesia society recommendation is capnography needs to be applied if you're given sedation, or really if you need to monitor ventilation at all. Now, we're also going to go over the idea of using capnography in monitoring blood flow. So I'm going to go show you how to use this in acute and critical care. One of the things that stood out to me when we were first doing this or looking at capnography, we've been doing this for over 25 years. I was with a patient who we had just extubated and seemed to be doing fine. Now, we had a capnogram on him, it was reading about 40. But he suddenly complained of shortness of breath. And his capnogram went from 40 to 10 literally in 1 second. And he was having severe trouble breathing. And what he had was a pulmonary embolism. And so a pulmonary embolism, as you can see from this slide, blocks blood flow. So there can be no CO2 added to that alveolar area. So the exhaled carbon dioxide level drops. We gave this gentleman a thrombolytic, and within about 15 minutes, his end tidal was back to normal, and he was comfortable. The point being is capnography can help identify changes in what we call physiologic dead space. So normally you might remember that an arterial end tidal gradient is pretty small, just a couple millimeters. But if that gradient widens, then the dead space is increased. And that could be due to a pulmonary embolism. It could be due to loss of blood flow. There's a couple reasons that could occur. So I want to show you how we, again, applied this initially. We've been doing this again for several decades, looking at capnography and resuscitation of patients. Again, all of you work in acute and critical care are pretty sensitive to the idea that people who have cardiac arrest, whether they're in-house or pre-hospital, the chance of survival is limited. What we wanted to do is, we still do, we want to make sure that we're resuscitating people that have a good chance for survival, that we don't continue unnecessary treatment for people who can't survive. And so a paper that was published, actually been looking at this, research has been studying this for several decades, but we really saw a good paper came out by Levine, Wayne, and Miller in the New England Journal of Medicine in 1997. And what they said was something very simple, is if the end tidal level doesn't rise above 10 after 20 minutes of resuscitation, there were no survivors. And this is something that many investigators, including us, have looked at over time. Now, the AHA has said, put a capnogram in place, because what this will do is help you identify when the person has return to circulation. Well, that's one of the most basic aspects of it, but it does work. There's really very little reason to check for pulse if you have a capnogram on. And again, I'll show you that in a second. So generally what occurs in a cardiac arrest is you lose blood flow to the lungs, huge increase in physiologic dead space, and you have and it's a reflection of cardiac output. So if you have an end tidal level that's less than 10, really almost at any point during resuscitation, but take it out to 20 minutes, If your end tidal is less than 10, you're going to have virtually no survivors. If the end tidal is higher than that, then that's okay. What we wanted to be able to do is just identify people who might have a chance of survival. And we'll give an example. This is well documented in the literature. This gentleman here had a very long resuscitation and survived. Now, this is an 1.5 hour resuscitation. Very, very unusual. But the thing that made this really a striking example was his end tidal CO2 level during the whole time. End tidal CO2 level was running 28 or higher during the resuscitation, showing that the first responders were doing a wonderful job of resuscitation. Now, this is unusual. In all my years, I've never seen anything like this. But what it points out is if you watch the capnogram during your resuscitation, you understand really what's occurring in terms of being able to help identify who's going to live or not. And so let me give you some examples. So let's take a look at this patient here. This was another person, one of our studies. She'd been brought into the emergency room. CPR was in progress. She'd been found down by her husband. So the paramedics have been doing CPR for over 20 minutes. She's had multiple defibrillation attempts. So on arrival in the emergency room, her capnogram is reading 6. What does that tell you? So if I had asked you a question, do you think we're doing a good job? Is ventilation great, but blood flow's poor? Will the patient survive? Well, the answer is this: if you have an end tidal of 6 after 20 minutes in resuscitation, the chance of this person's survival is so low as to almost be not measurable. And so the recommendation would be to stop the resuscitation effort. Give another example. So this is a 51-year-old gentleman admitted with pneumonia following an episode of the flu. He's found to be in cardiac arrest after the pulse ox alarm is heard. So CPR is occurring. Defibrillation for ventricular fibrillation has been performed 4 times. There's been no return of circulation noted. The effort's been going on for over 20 minutes. And again, the wife's in the room. Take a look at the end tidal reading. It's reading 5. So the question for you is, what should you do? Well, physiologically, you should stop the resuscitation efforts. Obviously, with the wife in the room, you want to make sure she understands what's occurring. The whole point being is that the end tidal is what's driving this. So we can actually even use this post-code. So this is a screenshot. I don't think it's real clear, but if you look in the bottom right corner where it says the expired CO2 is reading 18, this tells us this person has a not very good cardiac output. And we certainly would want to start doing some hemodynamic measurements of this person, because while it's certainly better than 10, it's not still very good. But in this particular case, they gave fluid to the person, and notice the end tidal went from 18 to 27. That's a really good response to a fluid administration, showing this person probably was hypovolemic. The other thing you can do, and many of you may already be doing this, is it's striking that if you just have a capnogram on during resuscitation, there's really never an indication to stop CPR, to stop chest compressions. Just watch your capnogram. If the person has a return of circulation, you'll see an immediate jump in the end tidal CO2 level. I've seen this many, many times, and I'll give you an example. So this would be an illustration during a code where we had an end tidal reading of about 15. And when the person had a return of circulation, we didn't even do anything. We weren't checking pulses or anything. We saw the end tidal jump to 30. There's only one reason for that, and that's because he had a return of circulation. And so the idea of stopping codes to check for pulses is something hopefully you don't do anymore, because it's not necessary. Just watch the capnogram. So when you look at how we would apply capnography as a summary in terms of resuscitation, capnography is very, very good at telling you who's going to survive or not. And it's also very good at telling you when a return of circulation is present. So that's a very simple way of using capnography, but we can actually go a step beyond that. We can go into a little more detail. The idea would be is that we can use capnography as an indicator of blood flow in a more general sense. And let me give you some examples of this. So this will be a 69-year-old gentleman who comes in with esophageal variceal bleeding. And so there's no indication that they're bleeding now from our GI lab people. And the question for you is, does he show evidence of hypovolemia? So one thing you can do is a passive leg raise. And if you see a jump in the end tidal CO2 level, you might want to consider, is this person hypovolemic? Because normally you wouldn't see a jump this big from 27 to 38. Now, once again, I want you to take a look at the other vital signs that are being used. The respiratory rate, the heart rate, blood pressure, and pulse oximeter. They don't show that there's a jump in perfusion, but the capnogram can. And it's by no means perfect in this respect, but it's really a good help in terms of identifying what you can do next. I'll give another illustration. So this is a 71-year-old female. She has a history of heart failure. She's admitted from an extended care facility. She's getting ready to be discharged to home. So she has no symptoms of discomfort. Her lung sounds are unchanged from yesterday. And so a question for you is her heart okay? Does she show any sign of worsening cardiac function? So the day before, notice her heart rate's 88, rest rate's 18, blood pressure looks good, pulse ox is good, and her end tidal's 30. So that's good. I would feel comfortable with that. But the thing that would bother me today, looking at her, take a look at the end tidal of 25. That's a decrease of 5 from the day before. That shouldn't happen. The idea would be is if we have an end tidal go from 30 to 25, there's a problem. And the problem is most likely be to a loss of blood flow. Now, physiologically, that means she's got an increase in physiologic dead space. If you would get a blood gas, that could be absolutely fine. But you would see a widening of the gradient between the arterial and end tidal levels, showing a loss of blood flow and an increase in physiologic dead space. So I'll give you another example. This illustration here, we have a patient admitted from the emergency room. They had a change in behavior and level of consciousness. Now, this was a gentleman who came in. He owned his own construction company. He had been at work and he had stepped on a nail that penetrated his boot and caused a wound to his left foot. So the idea would be is that he's home. He's taking care of this for a week at home, but his wife brings him in because he's acting different. He's not as easy to wake up. So this is now is a patient who you'd suspect is having sepsis. So what we do is we take a look at him, and right away he's tachycardic, he's tachypnic, so he's got 2 signs of SIRS. Clearly we're concerned about him. But I also want to check and see, is he volume depleted at this point? So we do a passive leg raise, and 1 minute after the leg raise, and this is the beauty of a capnogram. It tells you literally immediately what's going on. So the capnogram went from 29 to 37, showing that he is a volume responsive person. And so he's likely in need of fluid. And again, taking a look at the traditional parameters and traditional vital signs, we don't see that the person has a problem. That's one, at least not from the hemodynamic perspective. That's why the capnogram becomes useful. I'll give you another example, and then we're going to wrap this up. The idea is this particular case, we have a 57-year-old gentleman in cardiac rehab. He's had a ST elevation, acute MI. So he's able to perform his physical activities well. He's several weeks into the rehab process. You can see that he's on the standard post-STEMI medications. So what I want you to look at, though, is take a look at his exercise session. So prior to today, heart rate 74, rest rate 22, that's a little up. But his end tidal of 33, again, tells us that his cardiac output is probably fine. Now, today, take a look at his session. And what would bother you about this patient? If we take a look at this case here, what bothers me is his end tidal CO2 level now is reading 24. So that decrease is a warning sign that he's lost blood flow. And so what you're able to do with a patient like this is I would definitely have him reevaluated by his cardiologist. If I was a nurse at the rehab center, I would say that I think that he might be worsening because the end tidal shows that he's not tolerating exercise like he was before. Very simple test. Let the physician know about this, his cardiologist, and then he'll be able to do more in-depth assessments. So as you look at what we've talked about in a very short period of time, what capnography can do for us, and this is why it becomes the idea that a capnogram can be a new vital sign. So if I put a capnogram on a patient and they don't breathe effectively, for example, if we gave too much sedation or too much analgesia, what will happen is the end tidal will rise. And so we need to either then decrease the sedation or analgesia, or what we need to do is start to plan to support their breathing. Now, if the other thing, which is really what's fascinating about a capnogram, is it can be an indicator of cardiac output. So if I have a patient, and let's say I'm on a rapid response team, and I'm called to see the patient, and I would put a capnogram on and the reading is low, well, it could be one of two things happening. The person might be over-breathing, and so a blood gas would be necessary to tell us that. But it also could be indicating they're in heart failure. They could have lost blood. The idea being is that the capnogram will warn us before anything else will that what's going on in terms of blood flow. Now, it could also be a pulmonary embolism. And so when you look at the use of a capnogram, the ability for us to see multiple things with it, overventilation can be identified, the patient who's getting loss of blood flow can be identified. We have no other tool that can do that. That's simply non-invasively. So that's why it's considered to be really one of the newest vital signs. And you can apply it in terms of survival and cardiac arrest as well. If you can't get an end tidal level over 10, something's really, really wrong. And again, just to summarize and stop before I bring Angela on, if I have to look at a capnogram and see with one glance is my patient safe, if a capnogram's reading about 30, I know they have an adequate cardiac output and they're ventilating adequately. There's no other parameter we have that can tell us that much that quickly. So I'm going to turn this back over to Angela, and I think we have some questions. I apologize for some of the technical delays that we had, but we can address those as well. Angela, I'll turn it to you.
Thank you, Tom, for that most timely and thought-provoking presentation. I would like to remind the audience how they can obtain their CE credit. The educational activity has been approved for 1 contact hour for nurses, respiratory therapists, and EMS professionals. Nurses and RTs can obtain these CA credits by going to www.saxtesting.combo/BO. EMS can obtain CE credits by going to www.saxtesting.com/EMS. You will need to register at that site and complete the evaluation, and upon successful completion, you will be able to print your certificate of completion. We do want to say thank you to Philips for support for this educational activity. An archived/on-demand version will be available on better-outcomes.org. The on-demand version will be accredited for nurses and respiratory therapists. So with no further ado, we've got some questions, Tom. And so some very excellent questions. And the first question that came across was, is any one more accurate, side stream versus mainstream? Can you speak to that for us, for Mr. Singh?
No, they're both similarly accurate. The side stream analyzers started to be used as we got better microsampling techniques. We used to pretty much use mainstream analyzers that use near-infrared spectrometry to make, spectrophotometry to make readings. They're both fine. I like, if possible, the mainstream analyzer, simply because to do a side stream analyzer, there's a little bit of a delay in seeing the waveform on the monitor. But clinically, there's not a difference. If I were to want to do a reading like I showed on myself or anyone like in a clinic, they're not on a ventilator, then we're going to obviously be using a side stream analyzer. So, because basically that's what the handheld devices are. So, but they both work.
Okay.
I would not worry about that.
Okay, excellent. And can you remind folks of the procedure to actually perform a passive leg raise? And while you're thinking about how to explain that, someone also mentioned, the other question was, what percentage of increase with a passive leg raise would be considered that the patient would benefit from volume? So, and then I'll ask one more question about a passive leg raise in a moment. So if you can just explain that.
Yeah, the passive leg raise, and we actually probably should give a link to how to do the passive leg raise. But you're really just trying, now people can't have abdominal injuries with this or leg injuries. And so what you're looking at is someone who has neither one of those, and you want to elevate the legs at least 45 degrees to try and give basically an auto transfusion. Because the blood flow from the legs will then rush into the chest. And by doing so, that will tell you if the person is volume responsive. You probably want an increase of, first of all, any increase could be concerning. But if it goes up by about 10, then I think you have a fairly significant indicator that there could be a volume problem.
Okay, excellent. And I know that we do this at our hospital all the time. It's really nurse-driven at my hospital, and I think it's a great opportunity to look at all those hemodynamic variables together, including the end tidal CO2 as we do that. Now, one person mentioned that they were having the patient, let me get to this question, they were having the patient hold their leg up on their own for 1 minute. And the other question was, or is it putting them in Trendelenburg position? And I think we have to remember the importance of passive leg raise versus a patient doing it themselves. Isn't that correct?
Oh, absolutely. You definitely don't want the person doing it themselves. First of all, it's a very tough exercise. Yes. And then you don't want to do Trendelenburg. You want to just get the blood flow from the legs. And it's just temporary. You're just trying to make an assessment. You're going to return their legs back to their normal position.
I often call it the poor man's fluid bolus, right? I'm like, it's
Absolutely.
one thing that doesn't cost anything, right?
That's exactly right.
That is a great option. And then too, I don't know about you, but I've seen sometimes where we've done the passive leg raise and not had great response. And so we're like, thank goodness we can just lower their legs and let gravity do its work, right? And take that right away because it wasn't helpful for the patient.
That's exactly right.
So really important.
And
all right, another question. Yes,
real quick, the Capnogram isn't perfect. It's a good tool, but it's not perfect. So if you as a clinician think that there's something wrong and you want more specific measurements, you should do that. If you want to get a hemodynamic monitoring device, go ahead. But the Capnogram is a good tool, especially if you don't have those devices available.
Yes, excellent. Another question that has come up early in the presentation, you briefly mentioned end tidal CO2 with an asthmatic patient. How does that compare with patients with COPD?
The principle is exactly the same. Now, if you have chronic lung disease, you're going to have naturally a larger dead space. And so, again, for years and years in our ICUs, we monitored everybody's carbon dioxide. And so it wouldn't be uncommon to see an end tidal level in the 20s. Well, that was because of the lung disease that was present. But so here's what I advise all of you. What I use capnography really mostly for is a quick assessment. If I see a capnogram change quickly, something immediately just happened. That's an acute problem. So if I'm in the emergency room and a patient comes in with an end tidal of in the 20s, say 22, Well, I want to get a blood gas first of all to see what's their arterial level. If the end tidal's 22 and I get a blood gas and the blood gas is reading 25, well, that person's just overventilating. If the arterial level is 35 and I have an end tidal of 22, then something's wrong. And there's a good chance that they've lost some cardiac output, or they might have a small PE. So I start to go down that diagnostic pathway. So we're really looking for, you can use it to make an assessment of a new patient, but you can also use it as a monitoring tool. Like I said, if I go on a rapid response call, I'm bringing a capnogram because it's going to tell me so much right away. And like I said, if I have an end tidal of 30, it rules out pretty quickly any acute pulmonary or cardiac.
Yeah. And, they have so many different types of capnograms. So like you showed in your picture, very portable. And we've even recently, in the last couple of years, added a capnogram that we can actually put underneath our BiPAP machines so that when patients are struggling, so we can monitor that better. What are your thoughts about that?
Yeah, you bring up a really good question, Angela. Anybody who needs BiPAP, you probably should try and get capnography. Now, the problem is if you have a high flow system that can wash out the exhaled carbon dioxide, you have to be very careful because that can contaminate your readings. So your respiratory therapy department needs to be working with you to make sure your readings are going to be accurate. This is we struggle with whenever you put like high flow nasal cannula therapy in place. Well, that can really limit the capnography's ability to make an assessment because the high flow oxygen will just wash out the carbon dioxide level. So we do have a challenge on some patients in being able to monitor their carbon dioxide levels. Some of these we can overcome and some of these we can't. But certainly your respiratory therapy department can help with that.
Well, and that really brings us to our next question that Kim asked. Can the utilization of end-tidal CO2 take the place of NICOM in fluid management in our sepsis patients? And here's where I say that end-tidal CO2 is just another tool in the toolbox that can be very helpful, but do we take all these others out and put all of our eggs in one basket?
No, I wish we could, but we can't. So what I do with the end tidal is I find if there's a problem, and that because the end tidal can't tell us about stroke volume. So what we do is we get an idea: is hemodynamic monitoring necessary? And that's when we would go to things such as the NICOM, and any other cardiac output device you want to use. It's a wonderful question because that would be awesome if we could just use simple capnogram. It's not as sensitive as those hemodynamic monitoring tools are.
Yes, exactly. That's exactly. If we had just one device, wouldn't that be amazing? That could tell us everything.
That would be awesome, especially one as simple as a capnogram.
Right. So I have another question from Tiffany. I'm often present during conscious sedation procedures where we use short-acting medication. I often see a few minutes in the procedure a significant drop in the end tidal readings. What is happening in this scenario?
Well, that's a wonderful question. That would bother the heck out of me because the idea is if I lose my CO2 value, it goes down. There's not a lot of reasons for that. There's really two. One, the person's just overventilating, but I doubt that's the case if you just gave them sedation. What I'd worry about is, are you hurting their cardiac output? Now, hopefully this isn't something you see a lot, or that, if it was, I'd like to encourage you to monitor the patient's, hemodynamics, but it should indicate that they've lost some cardiac output.
Mm-hmm. Sure. And then Casey asked, would capnography be considered the gold standard for COVID patients? And I know you've alluded to some of the challenges with high flow oxygen, and I know we're using a lot of high flow oxygen, at least at my institution, for these COVID patients. So your thoughts about that?
Yeah, it's a wonderful question. Ideally in our COVID patients, we want to avoid intubating if we can. And so in order to do that, we've gone to high flow oxygen therapy, and in a lot of our cases, even using BiPAP. We might be able to use it on BiPAP. It's very difficult in high flow oxygen therapy. And so you might, unfortunately, you might not have the capnogram available. Now, the ventilator, completely different, but it's just difficult if you're flushing out the exhaled carbon dioxide.
Yeah, and that's what Rena asked too. She said, did you ever attempt end-tidal CO2 via non-invasive ventilation? She worries about the leak from the mask. Is that problematic? And I know we've got one system that doesn't work well, and we recently purchased a different end-tidal CO2 system that allows us to go right underneath that mask, much better. So what are your thoughts? Have you found some that work well and some that don't?
None that work well. The way that we've used it in our research studies is we put a nasal catheter in. So we actually go into the, beyond the airways. And that way we have less of a washout effect from a mask. Now, that may not be something everybody wants to do, but it certainly is better than, if you just have the nasal cannula, it's going to be washed out because of the high flow. So that is an area we haven't figured this one out yet, and I don't know that we will, but I would encourage you to have your respiratory therapist come up and see if they can help.
Yes, for sure. So you keep working on that, and then you get back with us, Tom. That's one of your objectives we're going to give you. All right, and Elizabeth asked, where is the best placement for the capnography adapter on the ventilator circuit? She said sometimes moisture does affect these readings. Do you have some suggestions?
Yep. Oh, yeah, moisture definitely can affect the readings. That's why a lot of people go to the microanalyzing, the micro sampling technique that reduces the contamination due to moisture. If you're using a mainstream analyzer, just make sure that the infrared sampler is on the superior at the top part, then let the fluid drain to the bottom. And put it as close as you can to the Y connector on a ventilator. That's really what you should be trying to do to avoid getting moisture problems. We found we don't eliminate the problem of moisture, but we really reduce it since we went to the microsampling technique. And that's been out for several years now.
Good deal. And then Nancy says, great presentation. But did I misunderstand you when you said we don't have to stop compressions if we are watching the end-tidal CO2? What about every 2 minutes for possible defibrillation?
Oh, yeah, please. If you want to defibrillate, you have to stop. I didn't mean to say that. I'm just saying if you're doing CPR, don't stop CPR to check for a pulse. Your capnogram will tell you that. So thank you for bringing that up. I don't want people going saying we shouldn't defibrillate.
Yes. And then Carrie states, do you have any troubleshooting techniques? She works in an outpatient procedural area, and many nurses disregard the end-tidal CO2. Just a moment. So sorry, I'm having trouble. There we go. Because the baseline is 22 or 56 or ... They just then assume it's inaccurate. Could you speak to this?
Yeah, again, it's a really good question, and we could have a whole another session on that. A normal end-tidal CO2 level is close to arterial, so say 30 to 35 is normal. That's what every one of us on this presentation will have. If you have an end-tidal reading in the 20s, like I said, either one of two things: a person's over-breathing, so they're hyperventilating, or they have a loss of blood flow in their lungs. There's not a lot of other reasons for that. If it goes up, like I said, the only reason for that is they're not breathing effectively. So, I've had people tell me the capnogram's not accurate, and we say, well, what do you mean by that? Because you can't. The only way you could test the accuracy if you put a precision carbon dioxide flow through the capnogram, and we do that, but most clinical areas aren't capable of doing that. So the capnogram is highly accurate. Every company that I've seen has a highly accurate capnogram. The question for us as clinicians is, what are we doing with that number? So, like I said, if we have a patient who the end tidal drops, something's going on with blood flow in their lungs, assuming they're not just hyperventilating. And if it goes up, we've done something to interfere with ventilation, or the person's going into respiratory distress. I'll give a real quick example. We had a patient who severe asthma came into our medical intensive care unit. The end tidal was reading 66. So we're concerned with that. Now, they also had COPD. So one of the questions was, is this just due to the COPD? So we got a blood gas. The arterial CO2 was 99. So even though the arterial CO2 was 99, the end tidal of 66 was still really high. And so we knew that that person needed ventilatory support. The idea being the capnogram didn't match the arterial, but it's not supposed to. It's just a reflection of, is the person not breathing adequately? So this is really a fun topic to go through, and I don't think clinically we teach it enough. And it's why people will say, I don't think this is accurate, because it's not been taught well. Hopefully presentations like this will help.
Absolutely. And this question and answer time has been so helpful for me. I know I've reached out to a rep before when I've had discrepancies from the arterial from the ABGs versus the capnogram. And then he sends me a note back saying, you know, you're assuming that this is inaccurate information. The reality is there's a lot of this education that we all need to understand about what's going on pathophysiologically. And at least it can lead us in the right direction.
Exactly.
So thank you for that. Yeah. Now, somebody brings up, and I know we only have time for just a few more questions, but it does, I want to address this. It says, in CPR resuscitation, the end tidal CO2 value is more valuable because the capnogram waveform is challenged to see and use due to compressions. Now, in my experience, it is very important that I see that waveform, and I don't like to trust a number without a good waveform. What are your thoughts?
Oh, I think it's a very valid question. You want to see a decent, exhaled waveform. You may not see it as well simply because the person isn't breathing, and if you're ventilating them, you should be able to see the normal waveform. But the research that we've done and others have shown that the capnogram by itself is valuable, even if you don't see the waveform. CPR is different because the person isn't breathing. And so you're not going to get the normal exhaled waveform. So you are looking a lot more at a number. But what's important to keep in mind, if we can't get the end tidal CO2 value to rise, we really have to question, are we getting adequate blood flow? So I understand completely the idea we have a nice waveform to look at, but the person isn't breathing. And so we're not going to see a normal end tidal waveform.
Yes. Well, my goodness, Tom, this has been great. I've loved these question and answers. I'm seeing a lot of really positive comments. People have been so grateful for this time where they can ask you these questions. So we thank you for that. And I think it's time for us to move on to the next slide. And thank you once again. And there we go. So I just want to conclude. And I want to thank everyone for attending this webinar. And remember, immediately on the conclusion of this, you will be presented with an online survey. And please keep your web browser open, and we do appreciate your feedback. And now I'm going to turn this presentation over to Monica. Thank you, Monica.
Thank you so much. Thank you both for that insightful information. It looks like it was really well accepted by everyone. Everyone's really raving about it. And thank you. And this does conclude our webinar for today. I would like to remind the audience that there is a survey for you at the conclusion. It will pop up immediately. We would greatly appreciate you sharing your opinion on today's webinar. We thank you again. And on behalf of our presenters, Sachs Healthcare Communications, and our sponsor, Philips, I hope you enjoy the rest of your day. Thank you.